Okay, let's start with hearing disorders. And again, there's not a ton of stuff with hearing, so we're just going to kind of focus on the things that you're probably most likely going to see. First of all, you got to remember your auditory anatomy, and this part is a little bit important to remember. So you've got your eustachian tube here. It actually runs all the way down here. This is your tympanic membrane. Now, if you'll remember from anatomy, you've got three bones in the ear. These three little moving parts. You've got your malleus, your incus, and your stapes. And these all have to be moving. When they're not moving, you're going to have some hearing problems. This is the cochlea, and the cochlear nerve comes in here, and the semicircular canals. These are filled with fluid. This apparatus is very responsible for your sense of balance, because if you remember, these semicircular canals are in three different spheres, and you've got little hairs in there. So when you're upside down or spinning, those hairs, the fluid moves against there, so that's how you can orient yourself. So your patients who are dizzy or have vertigo, the problem is in here. So need you to just kind of make sure that you remember your auditory anatomy. Then the next thing that I want you to remember is the external ear. So when I'm saying external ear, I'm talking from here out. This whole part is responsible for collecting sound. That's just what it does, is it collects the sound from the external environment. Then you've got your middle ear, which is right in here. This stuff is going to now start conducting the sound. It's interpreting it through vibrations. These little bones move, and it's going to start conducting the sounds back into the nerve that are going to get processed back in the auditory lobes of the brain. Then your inner ear is back in here, and this part is maintaining your equilibrium. And your tympanic membrane, this one vibrates. It's like the end of a drum, and that one is just going to respond to stimulus. So how do we know what kind of a hearing problem somebody has? There's two kinds of hearing problems. There is a conduction kind of problem, and there's a sensorineural conduction problem. So there's a couple of different assessment tests that we can do, and I meant to bring one down here with me. If I think of it, I'll bring it to class. We use a tuning fork, and I'm sure you've seen them, and you hold the base of the tuning fork and you hit it, and then the tuning fork starts vibrating like that. And in a Weber's test, you put the end of the vibrating fork on a person's forehead, like right here. So somewhere, up in here, that's preferably not on their hair, because what you're wanting to do is you're wanting to conduct the sound of the vibration through the bone. So then you can tell if you've got conductive hearing loss, and if a person has conductive hearing loss, the sound will be less. The sound is perceived by the ear with less hearing. So let me try to explain this. So let's say that the person, like if you do the hearing test, if you stand there and close your eyes and do this on each other, it's kind of fun. Close your eyes and then go like this. Just rub your little fingers together, and then see when the person can start hearing it, and see if they can hear it like here and here, and if those two distances are the same. In somebody who has conductive hearing loss, in the ear that they cannot hear this, if you do the Weber's test, they'll be able to hear it better in that ear than in the other ear. So that's how you can tell if it is a conductive hearing loss. And in a conductive hearing loss, is what's happening is you have a problem with the conduction. The sound that's being out here is not getting conducted. And that you test for that doing the Weber's test. So there is a difference between sensorineural hearing loss and conductive hearing loss. And I'm going to try to explain this. It gets a little bit confusing. But if you break it down, it's super simple. Your sensorineural is the nerves. It's basically involved in the nerves that are transmitting the sound. So the people that have a sensorineural hearing loss, it's either something is wrong in the cochlear region, or in one of the cranial nerves, like the vestibulocochlear nerve, which is cranial nerve number 8, or something in the central processing issue of the brain. So something along the actual nerve pathways that are interpreting the sound that's being heard, that's a sensorineural pathway. A conductive hearing loss is if there is a problem anywhere along the pathway. So it could be the tympanic membrane, it could be the middle ear. Sometimes these work together, sometimes they're completely separate. This might make it a little bit easier. So the conductive hearing loss usually results from some kind of interference with the sound waves. And this is a good depiction of it. So your sensorineural hearing losses usually occur in this part of the ear. Your conductive hearing losses occur in this part of the ear. And you'll notice these little bones are right divided in there because those little guys are responsible for the conduction of sound. So in functional hearing loss, there's no organic lesion. It's not going to be related to a tumor or something like that. Whereas that could be like in a conductive hearing loss kind of thing. So usually your sensorineural hearing losses are going to affect your inner ear. They're going to involve that 8th cranial nerve. Patients who have this, have a problem up here in the sensorineural, these are the people that are candidates for getting a cochlear implant. So sometimes people who have hearing loss or hearing damage can actually get cochlear implants in, and that helps them. That's sort of a permanent solution to hearing aids. A lot of people, many people can get hearing aids which will enhance sound, that will enhance the conductive sound in there. It's like putting a little microphone in your ear, but people who have problems back in here in a sensorineural area then are sometimes candidates for having a cochlear implant. So make sure that you're reading this because those two things, it's kind of important to know what kind of hearing loss or hearing problem your patient actually has. Now there are a bunch of reasons why somebody can have hearing loss. Some people are just born with a hearing loss and they're not sure why, or the mother may have had a problem, or something could be partially genetic. 33% of hearing loss are related to people who have been exposed to loud noises their whole life. So people that are working with heavy equipment, jackhammers, military, like arsenal things, loud, like airplanes, like being in airports or around train tracks, kids who go to loud concerts where the decibels are very, very high. Those things that are repeated over and over can actually lead to permanent damage in the auditory system and can lead to hearing loss. Infection or injury, again, like any trauma to the head or the acoustic area can lead to permanent hearing loss. Age accounts for about 28% of people who have hearing loss, because as people age, they tend to, those bones tend to get ankylosed. The word it would be stiff or tight, like they could get an overgrowth of bone around the stapes, so those bones, the malleus, incus, and stapes don't move like they're supposed to. So and the word for that is presbycusis, like presby again is old, and cusis is the word for hearing or auditory. And so as a person ages, both the middle ear and the inner ear can start having changes in it, which both can contribute to hearing loss and like their sense of stability, especially if they're having problems like in the cochlear and the semi-lunar circles. So there are some other causes that can lead to hearing loss that nurses especially need to be aware of. And we have a lot of medications that are actually ototoxic, so you do need to be very careful in some of your patients. A lot of our medications, like the mycins, can cause ototoxicity. The aminoglycosides, Some of the loop diuretics like Lasix can be ototoxic at times. Aspirin can lead to tinnitus and ringing in the ears, especially as a person ages, because as a person ages, a lot of these medications get filtered and metabolized through the kidneys. But with kidney changes, these medications are not excreted like they should be. They can start building up and they can lead to either hearing loss, ringing in the ear, which like tinnitus, diabetes mellitus, people that have had bacterial meningitis. I already talked about excessive noise exposure and age. These are all things that contribute to hearing loss in your patients. So that's why it's important to get a really good history and find out, what your person has been exposed to, especially if they're starting to have some problems with hearing. Another common disease, it's not common disease, but I'm sure you're going to run into it in your practice, is a disorder called Meniere's disease. We don't know why people get Meniere's disease. It tends to show up in people who are in their 40s and 50s. Unfortunately, there's not a cure. Although we do have some treatments for it, there's not a cure. But what happens in Meniere's disease is the cochlea and the semicircular tubules in here, they start backing up. They get overloaded with fluid and it starts getting swollen. So this whole fluid area of the middle ear starts getting edematous and swollen, and then it starts getting pressure, leading sending inaccurate or distorted information back to the brain. So what happens in patients who have Meniere's disease, they start getting vertigo, like a sense of falling, or a sense of dizziness, a sense that they don't know their space in the world, like this spinning motion. They get fluctuating hearing loss. It's kind of like, when you're underwater, you can't hear as well. It sort of feels like that for somebody with Meniere's disease. They get ringing in the ear, this tinnitus, like zzz, really annoying. They sometimes have difficulty sleeping because of it. So like fans and those noisemakers sometimes help drown out that constant zzz in their ears. And it can actually be very debilitating and life-altering. So this becomes a big nursing intervention. They can sometimes go in and do surgery to fix it, and that's usually if they've tried everything else. Sometimes they'll just remove those bones. Sometimes they'll have to extract fluid out of the canals. There is this thing called a rebalance therapy. It's like physical therapy, teaching somebody to rebalance themselves, despite the fact that the cochlea and the semilunar circles are out of whack. So they work with a physical therapist who's trained in this to try to prevent falling and helping them to rebalance. Sometimes because you know how like when you're in on a ride and you're spinning and then you kind of get nauseated and sick a lot, they tend to have that. So sometimes these patients are on antiemetic medications. Motion sickness, like people who get seasick, they can put them on those kind of medications. That sort of helps subside some of the side effects of it. They can go on some hearing aids, especially if they've got that fullness in their ear. There's a lot of hearing aids available. Diuretics will sometimes help to get rid of some of that fluid, but unfortunately there's no cure for it. Oftentimes the good news is it does go into remission, but then it tends to come back, unfortunately. There's a million nursing diagnoses and management when you're taking care of your patient who has Meniere's disease. They are at high risk for fluid volume deficit. One, because they're on diuretics. Two, because they are nauseated a lot. They don't tend to drink or eat as much. So you do want to encourage them to drink a lot of fluid, non-caffeinated, obviously, low sugar, give them antiemetics. I already told you about motion sickness. They are at high risk for injury, so you've got to be careful that you're making clear paths for them. Maybe have handrails around, that very, very cautious around stairs. Don't put any, like throw rugs down that they can fall on, things like that. Trauma, especially when they're ambulating, you don't want these people falling and hurting themselves. the risk for injury, risk for trauma are kind of closely associated, and high anxiety because of the illness. It's very debilitating. It's hard to drive. There's no cure, and so and oftentimes somebody doesn't know why they're having it. It takes a while to figure it out. And if they've been taking too much aspirin, they just have tinnitus. Do they got something else going on? So tell the patient what's going on. Tell them what some treatment options are. You try to educate them on what the disease is. Try to have them help participate in activities of daily living and maybe fitting them for hearing aids, telling them about some of the different therapies that are available to try to decrease their anxiety. Another problem that we have in the hearing world is acoustic neuromas, and we talked a little bit about acoustic neuromas when we did Neuroscience Week. But I just wanted to reiterate it here. See, this is the back of the head on an MRI. This is the guy's head. Here's his ears right here. This is the middle septum of the brain and the ventricles here. And you'll see right here is this neuroma is starting to grow. And here's the ear. The acoustic nerve is going right in through here, and this is going to press on it. So this person is going to start having hearing loss on this side of the ear. Most of the time it's benign. And you can see how it's nice and round and encapsulated. It's usually just like, it's a meningioma, it's a neuroma arising just out of the normal tissues in the brain. It's not a malignancy, but nonetheless, a person will start developing hearing loss in this ear, and it does have to go in and be removed surgically. These patients will often have the same symptoms with tinnitus, vertigo, things like that until it's removed. But they don't have to have chemotherapy or radiation because it's not malignant. They'll just go in. The surgeon typically just goes in, does an incision right in here, goes in, removes it, and that's the end of that. And they're usually okay afterwards. That's acoustic neuroma. The other things that I wanted to tell you about with the ear that are pretty common is otitis media. If you work in pediatrics, you will absolutely be dealing with otitis media. When you look in somebody's ear with an otoscope, and I want you guys to do this if you haven't already, this is what the eardrum looks like. This is a normal, healthy, pearly looking eardrum. There's no redness or swelling. This is a nice, clean eardrum. That's what you should be seeing when you're looking in somebody's ear with that otoscope. This is a person who has otitis media. Basically, it's an infection in the eardrum and the ear canal. This is very common in little kids. Little kids have very short little ear canals. They are often underwater. You'll see this a lot in the summertime. Kids love to go swimming. They get out. It's nice, dark, and moist in there, and they end up getting otitis media. Otitis media is very painful. It hurts really, really bad. So here's the deal. It used to be in the past that a little kid would come in, and this hurts 1,000 times worse in an adult. It does occur in adults, adult onset otitis media. So you absolutely have to treat pain because it is super painful. However, it used to be that little kids would come in, we'd put them on antibiotics. They'd all get antibiotics. Well, now studies are showing that antibiotic treatment is it's not as effective as just waiting it out for 2 or 3 days, and the infection will go away on its own. Treat pain, treat symptoms, keep the kids out of water, keep the ears clean and free of water, and usually it'll go away, and then you don't have that problem of bug resistance that all these the superbugs are forming because of overuse of antibiotics. So that's just one thing you might start seeing in the literature. Cerumen is a fancy word for wax. This is what wax buildup looks like in the ear. This is another reason why it's important when your patient is starting to tell you that they can't hear. Here's a neat thing, your patients will not tell you they can't hear. People who are losing their hearing, they don't know they're losing their hearing, but they'll start turning the TV up, they'll ask what a lot, they can't hear, but they don't want to admit that they have hearing loss. This is very, very common. And so this is when, like, you start doing the hearing test, you've got to prove to them that yes, they in fact do have some hearing loss, put some hearing aids in them, and then all of a sudden they can hear a lot better, and they're not shouting, and their wife's not shouting at them. But you absolutely have to just at least look in their ear first, because this can easily be treated. You never, as a nurse, never ever ever put anything in somebody's ear, and you will also tell them don't jam stuff in their ear. Little kids, you're constantly going to see this. They're constantly sticking pebbles and things in their ear, and they have to come to the ear, and we scoop it out. But that has to be done by a trained person, because it either has to be done by an otolaryngologist or somebody who's trained in this, because anytime you stick something in somebody's ear, this, you can see how thin this is, you run the risk of rupturing that eardrum. So you do need to be very careful. So with somebody that has wax in their ear, you can try a little bit of warm water, and just to see if that will melt it. You put the warm water in and have them hold it there, and then they lay on their side and have it hopefully drain out. If that doesn't work, there's some over-the-counter wax dissolvers. The thing that you have to be careful of with those is it's just drops that they put in their ear. But you got to be careful that it doesn't dissolve the wax and it leaks back down inside there and then reseals. So you have them put the wax in there, the wax dissolver, for just a couple of minutes, and then tip their head this way so the wax can drain out. If none of that works, then you go in to see the physician, who then is trained to go in with a little, it's like a little curette thing, and they can scoop out the cerumen or the wax. So that's what we do for wax in the ears. These are super common. That's it. That is all I have. So there's not a lot of ear stuff, and not a ton of eye stuff either. So this should be an easy week, and that's it. So there you go. Call me if you have questions.